welcome to the deep dive. Today we're tackling a really intricate and vital topic: thoracic aortic aneurysms, or TAAs. I've got a collection of expert insights here that illuminate how we're increasingly using, catheter-based techniques, these endovascular strategies, to address these complex conditions.
Right.
Think of your thoracic aorta as, well, the body's main water pipe from the heart, running right through your chest. When a section weakens and balloons out, that's an aneurysm.
And it's interesting, while it affects about 10 out of every 100,000 people annually, it definitely becomes more common as we age.
Right.
And unlike abdominal aortic aneurysms, which you hear about more maybe, and they're more prevalent in men, thoracic aneurysms seem to affect women and men pretty much equally.
Now, where these aneurysms pop up really cranks up the complexity.
Absolutely.
While they're more frequent maybe in the ascending aorta right near the heart, or the descending aorta further down aneurysms that involve the aortic arch, that critical curve at the top, or the thoracoabdominal aorta where it extends down into the abdomen, well, they're a different beast altogether.
Yeah, a whole different challenge. Only about, 15% involve the arch and maybe 10% the thoracoabdominal area, compared to the ascending or descending ones, which are much more common.
Exactly. And traditionally, fixing these more involved aneurysms with open surgery carried some, pretty substantial risks.
That's really the key driver behind this significant shift towards endovascular solutions we're seeing. Instead of major open incisions, we're using catheters inserted, through blood vessels. So this deep dive will specifically explore these endovascular approaches for those really challenging thoracoabdominal aortic aneurysms, or TAAAs, and the aortic arch aneurysms.
Okay.
Just keep in mind that the specifics of the endografts themselves, the actual devices, and the really detailed procedural planning that's covered elsewhere in another chapter, so to speak.
Right. So your mission today, the listener, is to really understand the main strategies and the crucial considerations for using these endovascular methods to repair these complex aortic aneurysms. We're drawing on a wealth of expert knowledge here to bring you the essentials. Okay, let's unpack this, starting with those thoracoabdominal aortic aneurysms, the TAAAs.
Okay, so the core aim when dealing with the TAAA is, pretty straightforward. It's to help people live longer, meaningful lives by preventing that potentially fatal rupture of the aneurysm.
Makes sense.
Now, when we find an intact aneurysm, one that hasn't ruptured and isn't causing symptoms, deciding whether to intervene surgically involves a really careful balance.
Yeah, it's not automatic.
Not at all. We have to weigh the potential downsides, the risks of the repair itself, against the risks of just, monitoring the aneurysm, the non-operative management.
That makes perfect sense. It's definitely not a one-size-fits-all situation, is it?
Not even close.
What are the key things doctors are looking at when making that call?
Well, we look at several factors. The potential for complications or even death from the surgery itself, obviously. Then the likelihood of the aneurysm bursting based on its current size, how quickly it seems to be growing, and really importantly, the patient's overall life expectancy and their quality of life. You got to factor all that in.
And when we talk about that danger of rupture, I know size is a major indicator. How do doctors actually, measure the size? Is there a standard way?
Yeah, aneurysm diameter is indeed our most reliable predictor of rupture risk, at least right now. We measure it on imaging, like a CT scan, from the outer wall of the aorta to the opposite outer wall. And critically, we make sure we're looking at it from a straight-on 90-degree angle, what we call orthogonal view, to get the true maximum diameter.
Okay.
Current guidelines, like those from the European Society for Vascular Surgery back in 2017 and a U.S. task force in 2010, they generally suggest repair for patients considered low to moderate risk when the aneurysm gets larger than about 60 millimeters in diameter.
60 millimeters, okay.
Now, that threshold might be a bit lower for people with certain conditions, like connective tissue disorders, which make the aorta weaker. And we also really pay attention to rapid growth, say, more than 10 millimeters in a single year, or if the patient starts experiencing symptoms related to the aneurysm. Any of those could trigger intervention even below 60 millimeter.
That's really interesting. And, with these newer, less invasive endovascular techniques becoming more common, do you think that 60 millimeter trigger point might change in the future? Like maybe we'd intervene earlier?
That's a really insightful question and something we discuss a lot. The thinking is that if total endovascular repair consistently proves to be significantly lower risk than traditional open surgery, then yes, we might consider intervening at slightly smaller aneurysm sizes down the line.
Right.
But, and this is a big but, we really need more solid long-term data to be sure about the durability and overall benefit before we make that shift widely.
Okay, makes sense. So let's get into the nitty-gritty of these endovascular techniques for TAAs. I keep hearing the term FBVAR. What exactly is that?
Okay, yeah, FBVAR. It stands for Fenestrated and/or Branched Endovascular Aortic Repair.
Right.
Now, because TAAs happen in the part of the aorta that supplies blood to crucial organs like your kidneys, your intestines, your liver, any endograft, any stent graft we put in has to span this area.
Okay.
So the real trick is to make sure we maintain blood flow to these critical branch vessels. Think of it like patching a pipe, like you said, but one with smaller pipes branching off. You need to make sure your patch doesn't block those smaller pipes.
And that's where the fenestrations and branches come in, right? They're like little customized openings in the main graft.
Precisely. Fenestrations are essentially very precisely placed holes or openings in the fabric of the endograft itself. Branches, on the other hand, are short pre-attached tubes that stick off the main graft body.
Got it.
By carefully lining these fenestrations or branches up with the openings of the visceral and renal arteries, we can then use shorter connecting stents, we call them bridging covered stents, to link the main endograft to these target vessels. This guarantees that blood continues to flow to those vital organs.
Okay.
FBVAR has actually been used for about 2 decades now, believe it or not. And similar to other endovascular approaches like TVAR for the thoracic aorta or EVAR for the abdominal aorta, it's generally associated with lower rates of complications and death compared to the big traditional open surgery.
That sounds like a huge step forward. Really significant. But I also read that it's, well, a technically demanding procedure. And maybe there are still some questions about how well these repairs last long term.
You're absolutely right on both counts. It definitely requires a high level of technical skill and experience. There's a steep learning curve. And yes, long-term follow-up is absolutely essential to make sure these repairs remain durable and effective over many, many years. We're still gathering that long-term data. Now, when we talk about the actual devices used in FBVAR, we have a few different categories, really.
Okay, tell me about those. What are the different types of devices? What options do surgeons have?
Well, we primarily have what we call physician-modified endografts, or P-MEGs. Then there are custom-made devices, or CMDs. And increasingly, we're seeing off-the-shelf options that are being tested in clinical trials.
Physician modified. That sounds like the surgeon is doing some on-the-spot tailoring right before the procedure, like customizing it themselves.
Exactly that. With a P-MEG, a physician takes a commercially available standard endograft off the shelf and, just before implanting it, makes specific modifications to it right there in the operating room, or maybe just beforehand.
Wow.
Using detailed measurements from the patient's CT scan, they'll carefully create those fenestrations, or maybe even add small branches using specialized surgical tools. These openings are then reinforced, usually with radiopaque markers so we can see them on X-ray to prevent leaks. And then the modified graft is very carefully reloaded into its delivery system.
That's intricate.
It is. And there's even some exciting research looking into using 3D printing to create templates, basically, to make these modifications even more accurate.
Oh.
PMs are particularly valuable when a patient comes in with a symptomatic TAAA. Maybe it's starting to cause pain or problems, and they need urgent treatment. They just can't wait the several weeks it might take to manufacture a custom-made device or get into a specific clinical trial.
Right. Speed is key there.
Absolutely. And there's also a newer technique called in situ laser fenestration, where an off-the-shelf graft can be quickly modified with a laser inside the patient during the procedure itself in real emergency situations.
That sounds pretty cutting edge. What about these custom-made devices, the CMDs?
Yeah.
Sound even more tailored, maybe.
They are. Custom-made devices, or CMDs, offer the highest degree of personalization you can get. They can incorporate almost any combination of fenestrations and branches, positioned in various directions and at specific angles to perfectly match the unique, complex anatomy of a particular patient's aorta and branch vessels.
So really bespoke.
Exactly. In the U.S., access to these is mainly through clinical trials or special physician-sponsored research studies, what we call PSIDEs. Directional branches, which kind of point away from the main graft, are often preferred when there's a longer distance to cover between the main graft wall and the target vessel, say more than 35 millimeters inside the aorta.
Okay.
CMDs can also be designed with preloaded catheters already inside the branches to make it easier to guide wires into them during the procedure. procedure. Plus, they can be tapered in shape, which is useful for patients with chronic dissections where the main channel of the aorta might be narrowed. And they can even be made with a smaller profile, fitting through an 18 French sheath, which is quite small, allowing access through smaller arteries.
So very adaptable.
Very. Despite their more limited availability currently in the U.S., there's a significant amount of experience worldwide showing that they can be implanted safely and effectively when done by experienced teams.
And finally, the off-the-shelf options. That sounds like it would simplify things a lot just in terms of logistics and availability, right?
That's certainly the hope and the major advantage. There are several off-the-shelf FBVAR devices currently undergoing clinical trials in the U.S. from different companies.
Okay.
The big plus here is avoiding that sometimes lengthy 6 to 8 week manufacturing period you have with custom devices. You could potentially treat patients much faster.
But there must be a downside.
There is. The trade-off is that their standardized design, by definition, won't fit everyone. It might only be suitable for the specific anatomical features of maybe 50% to 60% of patients with TAAAs, so it won't be a universal solution.
Right. Still needs careful patient selection. Okay, so we've got the different device options. What about the actual procedure itself? How is this FBVAR surgery typically performed?
Right, the operation. FBVAR is typically done in a specialized hybrid operating room, which combines high-quality imaging capabilities with a sterile surgical environment. It's usually under general anesthesia. We gain access to the arteries, usually in the groin, the femoral arteries, and we often place a temporary drain for the spinal fluid, a lumbar drain, especially if we anticipate covering a significant length of the aorta with the graft. This is a key step to help protect the spinal cord from injury.
That neuroprotection aspect again.
Exactly. And while not always strictly necessary, using fusion imaging is incredibly valuable. This technology overlays the detailed preoperative CT scans directly onto the live X-ray images during the procedure.
Like augmented reality for surgeons.
Kind of, yeah. It helps us reduce the amount of contrast dye needed, which is better for the kidneys, can shorten the procedure time, and minimizes radiation exposure for everyone in the room.
Good benefits.
Definitely. We always need access through at least one femoral artery in the groin. But depending on our specific plan for accessing the target organ arteries, we might also need additional access points, maybe the opposite groin, or sometimes even an artery in the arm, like the brachial or axillary artery. The main steps involve carefully guiding the main endograft up into the aorta under X-ray guidance. Then, the critical part. Precisely aligning the fenestrations or branches with the openings of the visceral and renal arteries. This is where that fusion imaging is really clutch.
I can imagine.
Once aligned, we insert specialized wires through the graft openings into those target vessels. These wires are then exchanged for stiffer wires that provide support. And then over those stiff wires, we deploy the bridging stents. These deploy so their proximal end is inside the fenestration or branch, and the distal end is inside the target vessel, creating that sealed connection. We often use a balloon to flare the end of the bridging stent inside the main graft for a good seal.
Right, and you mentioned these bridging stents. Are there specific types of stents that are preferred or, designed specifically for this purpose?
That's an important detail, and it's a bit complex currently. While several different types of covered stents can be used for bridging, there aren't actually any that are specifically FDA approved for this particular application just yet.
Oh, interesting. So it's sort of off-label use.
In a way, yes. And because of that, there's no single agreed-upon ideal stent or combination of stents. Different surgeons have different preferences based on experience and the specific situation. What we do know is that we absolutely must use a covered stent to effectively seal off the aneurysm from the target vessel.
Okay, needs to be covered.
Yes. Ideally, these bridging stents need to be accurate to place, flexible enough to navigate the curves of the vessels, strong enough to withstand the constant movement and pressure inside the aorta over time, and have a low profile so they can fit through the delivery systems easily.
That's a lot to ask of a stent.
It is. We have both balloon expandable covered stents, which are mounted on a balloon and expanded into place, and self-expanding covered stents, which spring open on their own once deployed. Each type has its own pros and cons.
Right.
Which leads to some ongoing discussion among surgeons about which is best in different situations. The choice might even depend on whether we're bridging from a fenestration, one of those holes, or from a pre-attached branch on the main graft.
Interesting. So are there different considerations when using bridging stents with fenestrations versus with branches? Does it change the choice?
Yes, there can be some nuances. When bridging from a fenestration, balloon expandable covered stents are probably the most commonly used currently. Some popular examples are the Atrium iCast, the Gore Viabon VBX, and the Bentley Bagraft.
Okay.
The Viabon VBX, for example, offers more flexibility because its metal supports aren't connected all the way along its length. But there's a slight theoretical concern that the unsupported gap between supports could potentially not line up perfectly within the small fenestration.
Potential small gap.
Potentially. Also, using a stiffer balloon expandable stent in a very curved or tortuous vessel can sometimes actually worsen the curve, which could potentially lead to kinking or blockage down the line. In those tricky situations, surgeons might choose to extend the bridging stent with a flexible bare metal stent just beyond the covered portion for better conformability.
Got it.
Now, when using the pre-attached directional branches, both balloon expandable and self-expanding covered stents are commonly used. Examples include the Gore Viabon, which is self-expanding, or the Bard Fluency. There's been increased use recently of the balloon expandable Viabon VBX in branches too, with some good early results reported in terms of how well it stays open and stable.
Okay. Lots of options and ongoing evaluation there. Now, what about patients who have a chronic aortic dissection in addition to their aneurysm? That sounds like it would make the endovascular repair even more complicated.
Oh, it certainly adds a significant layer of complexity, yes. Chronic dissection, where there's a tear in the inner layer of the aorta creating a true lumen and a false lumen, presents several major technical challenges.
Like what specifically?
Well, we have to carefully figure out where we can achieve a good seal for the endograft, usually needing healthy aortic tissue above and below the dissected area. We have to manage potential compression of the true lumen, the main channel, by the pressurized false lumen. We need to identify which crucial branch vessels originate from the true lumen and which might come off the false lumen. And we have to be aware of smaller arteries, like intercostals or lumbars, that might feed the false lumen and cause leaks later.
Oh, okay.
In these cases, the main endograft is almost always deployed within the true lumen, so accurately identifying the true lumen versus the false lumen on imaging is absolutely critical. We might use intravascular ultrasound, IVUS, during the procedure, or rely heavily on careful analysis of the preoperative CT scans, maybe with 3D reconstructions, to help map everything out.
Right.
If it's difficult to guide a wire up into a compressed true lumen from the groin access, we might need to try accessing it from an artery in the arm instead, working downwards an antegrade approach.
Makes sense.
Fenestrations are often preferred over branches when dealing with a compressed true lumen, mainly because there's a risk that a branch extending into that narrowed space could get squashed or collapse. Specially designed tapered endografts, which narrow down along their length, and delivery systems that have preloaded catheters for the renal artery fenestrations can also be very helpful in these tricky dissection cases.
And what about getting blood flow to vessels that come off the false lumen?
That's another challenge. Identifying the original tears or entry points in the aortic lining on the CT scan is crucial. Sometimes we can pass a wire from the true lumen through the tear and into the false lumen to then cannulate the vessel originating there.
Right.
We might even need to intentionally create or enlarge a small tear, maybe using a special needle or even a laser, if a suitable one isn't readily apparent to allow access. The length of the bridging stent needed to go from that tear across the false lumen to the actual vessel opening becomes really important, as too short a stent could lead to leaks, what we call type 3 endoleaks.
Sounds very complex.
It is. And early endoleaks are relatively common after FBVAR in chronic dissections, often coming from those smaller intercostal or lumbar arteries feeding the false lumen, or sometimes retrograde flow up the false lumen. Interestingly, though, even though many patients might have this type of leak initially, it doesn't always cause the aneurysm sac to grow or become problematic.
Well,
Because accessing these leaking vessels after the main procedure can be challenging, some teams might consider proactively blocking off or embolizing larger lumbar or intercostal arteries, or maybe the inferior mesenteric artery during the initial procedure. This might also offer some added protection to the spinal cord by encouraging collateral flow, and it addresses the potential leak source up front. Secondary procedures just to embolize the false lumen itself have also been reported.
it really sounds like advanced imaging technology is absolutely essential for planning and executing these intricate procedures. I noticed a mention in the source about trying to reduce the reliance on traditional X-ray-based fluoroscopy.
Absolutely, that's a major focus. Because FBVAR procedures are so detailed and can be lengthy, they often require longer periods of fluoroscopy, which, as you know, uses ionizing X-ray radiation.
Right, which carries risks for both patient and staff.
Exactly. While CT fusion technology, which we talked about, has been a great help in reducing time and dose, it still fundamentally relies on that 2D fluoroscopy guidance. So there's a real push in research and development to incorporate more non-ionizing imaging methods.
Like what kind of methods?
Well, intravascular ultrasound, or IVUS, which uses sound waves from a catheter inside the vessel, has been used as an additional tool, an adjunct, for some time now to get better views of the vessel walls and lumen.
Okay.
Then there's some really exciting research into things like endovascular robotic catheters. These would allow surgeons to remotely control the instruments with high precision from a console. Well, this could potentially reduce their exposure to radiation significantly and might even offer more stable and precise movements than human hands can achieve. Early studies have shown it's feasible, but we definitely need more clinical data to fully understand their benefits and cost effectiveness.
Makes sense.
Another promising area is electromagnetic navigation systems. These combine the preoperative CT scans with real-time tracking of catheters and wires using low-strength magnetic field, kind of like a GPS system inside the body. These have shown success in laboratory and animal studies and are just starting to emerge in clinical use.
Very cool.
And finally, perhaps the most futuristic is fiber optic real-shape technology, or 4Rs. This is still in the very early stages of development, but has the potential to be a real game changer. It uses hair-thin fiber optic cables embedded within the catheters and guide wires to provide a continuous, real-time 3D visualization of their exact shape and position inside the body, all without needing any fluoroscopy at all.
That would be
It
incredible.
really would. Transformative potential, but still early days.
This is all incredibly complex. It really sounds like for some patients, a completely endovascular approach like FBVAR might just not be the best fit, or maybe not even possible anatomically.
That's absolutely correct.
So that's where hybrid repair strategies come into play, right? A mix of techniques.
Exactly. Hybrid repair is an important alternative for patients where a total endovascular solution is either too technically challenging due to complex anatomy, or perhaps they have limitations in their blood vessel access, like severely diseased femoral arteries. And crucially, it's for patients where traditional open surgery would carry an unacceptably high risk due to other health problems.
So it bridges a gap.
It does. It's essentially a combination of TAAAs placing a standard thoracic endograft to cover a part of the aneurysm with an open surgical component. This surgical part can either be an open repair of the arteries, supplying the abdominal organs that are connected directly to the bottom of the endograft. We call this the antegrade approach, usually involving opening the abdomen, or, more commonly perhaps, a surgical bypass procedure to reroute blood flow to those critical visceral and renal arteries, with the bypasses originating from the aorta or iliac arteries further down, below the aneurysm. This is the retrograde debranching approach.
Okay, tell me more about that retrograde approach.
Sure. This retrograde debranching, where we create bypass grafts, usually starting from the iliac vessels in the pelvis, and tunnel them up to connect to the visceral and renal arteries, is still a significant open operation, usually through an abdominal incision. However, it avoids needing to open the chest cavity, avoids directly clamping the diseased aorta high up in the chest or abdomen, and significantly reduces the amount of time the abdominal organs are without blood flow compared to a full traditional open TAAA repair.
So potentially less traumatic overall than the full open.
That's the idea. This potentially lower level of surgical trauma might translate into fewer major complications immediately after the operation.
So who might be a good candidate for this hybrid approach specifically?
Well, the general reasons for considering intervention are the same as for a total endovascular repair, primarily an aneurysm diameter greater than about 6 centimeters or rapid growth or symptoms.
Right.
However, we particularly consider the hybrid approach for patients whose overall health and other medical conditions, like severe heart or lung disease, might make a standard open repair just too dangerous. We still need adequate healthy sections of the aorta, usually in the descending thoracic aorta, where we can securely land and seal the thoracic endograft component.
Makes sense.
In that antegrade approach, after placing the TAAAs, the surgeon would then temporarily clamp it off and surgically reconstruct the visceral vessels downstream, either individually with bypass grafts or sometimes using a patch of graft material with multiple vessels sewn to it. In the more common retrograde approach, we have to carefully plan where the bottom end of the TAAA will sit, the distal seal zone. We need to make sure it doesn't block or impinge on the origins of the bypass grafts coming off the lower aorta or iliac arteries. We typically use Y-shaped Deckrin grafts for these bypasses, often with 6 or 7 millimeter limbs, and try to configure them in a gentle C-shape curve to avoid any kinks as they travel upwards.
Right.
The connection to the target abdominal artery, like the renal or mesenteric artery, is usually an end-to-end anastomosis, meaning we cut the target vessel and sew the graft directly to it. Or if it's an end-to-side connection, we'd usually tie off the original vessel just beyond the connection point to prevent leaks back into the aneurysm sac.
Got it.
We also need to carefully assess the quality of the iliac and femoral arteries in the groin because we might need to use them again for future endograft procedures, perhaps if the TAAA needs extension or revision later. Sometimes a separate conduit or tube graft is tunneled to the groin to preserve future access.
Okay. And are these hybrid procedures usually done all at once or in stages?
They are often done in stages, staging the open bypass surgery first and then bringing the patient back for the TAAA placement a few weeks later. The rationale is to reduce the overall operative time and physiological stress of one very long surgery, hopefully reducing the risk of complications.
Makes sense.
They can be performed in a single operation, but staging is quite common. However, a potential downside of staging is that there's a small but real risk, maybe up to 10% in some series, of the aneurysm rupturing during that interval between the stages. So that's a serious consideration.
Yeah, definitely risk to weigh. And what do the outcomes generally look like with this hybrid repair approach compared to the other methods? Is it significantly better than open?
Well, despite the potential theoretical advantages of avoiding the chest opening and aortic clamping, the reported rates of major complications and death after hybrid TAA repair are still relatively significant. Looking at various studies, complication rates range roughly from 20% to 33%, and mortality rates from about 4% to 14%.
So still quite high.
They are, and sometimes comparable to outcomes reported for open surgery, especially when you look at meta-analyses which pool data. For instance, one meta-analysis suggested rates of permanent spinal cord injury around 4.5%, renal failure needing dialysis at 8.8%, and prolonged ventilation over 8%. So it's certainly not a minor procedure, right? It's important to remember, though, that these numbers often come from single medical centers, maybe with specific patient populations, and might not represent the whole picture. The good news is that the bypass grafts themselves, the surgical part, tend to remain open and functional very well over the long term, with patency rates often exceeding 95% at 3 years.
That's good.
And interestingly, while the initial cost of a hybrid repair might seem high because of the multiple components and potentially staged procedures, some economic analyses argue that it could actually offer better overall value to the healthcare system in the long run by potentially reducing the very high costs associated with treating major complications like kidney failure or prolonged ICU stays, and maybe fewer hospital readmissions compared to some outcomes after open surgery. But that's still debated.
Okay, interesting perspective. Let's switch gears again slightly and talk about how all these different approaches, traditional open surgery, this hybrid repair we just discussed, and the total endovascular FBVAR actually compare when we look at the overall results for patients. How do they stack up?
That's really the million-dollar question, isn't it? And it's a really critical comparison. We know that traditional open TAA repair is a very technically challenging major operation. Historically, it's been associated with significant rates of both morbidity, major complications, and mortality, death.
Right.
Even with all the advancements we've made in surgical techniques, anesthesia, and postoperative critical care over the years, we still see notable rates of serious complications like spinal cord injury, maybe 6 to 13%, permanent injury, and some series significant kidney failure requiring dialysis in around 8%. And death within the first 30 days after surgery hovering around 6 to 9%, even at the very best, high-volume specialized medical centers.
Wow, even at the best centers.
Yes.
Right.
And if you look at data from larger national databases, which reflect broader real-world practice, the mortality rate after open TAAA repair might actually be closer to 20%. So it's a very high-risk operation.
Okay.
Now, as we just discussed, hybrid repair outcomes in terms of complications and mortality can sometimes look somewhat similar to those seen with open repair in some reports, with those morbidity rates of 20-33% and mortality of 4-14%. However, when we look at total endovascular repair using FBVAR, particularly the results coming out of experienced centers that do a lot of these, the outcomes often appear more favorable, at least in the short to medium term. We generally see lower reported rates of operative mortality, often in the 0 to 5% range, lower rates of permanent spinal cord injury, maybe 0 to 4%, and less acute kidney failure requiring dialysis, perhaps 1 to 5%.
That sounds significantly better.
It does seem quite promising. And the bridging stents used in FBVAR also tend to remain open and functional quite well, with primary patency around 95% and secondary patency, meaning open after some intervention, close to 98% at 3 years in some studies.
But there must be a catch with FBVAR too.
There is. A significant one is that unplanned reinterventions needing to go back later to fix something, like addressing endoleaks, bridging stent issues, or other problems, seem to be considerably more common with FBVAR compared to open surgery. Some studies report reintervention rates as high as 46% over time.
Wow, nearly half might need something else done.
In some cohorts, yes. So the long-term durability and the need for ongoing surveillance and potential reintervention is a key factor with FBVAR.
It sounds like directly comparing these different approaches is a bit of an apples to oranges situation in many cases, given the different patient risks and aneurysm types.
You're absolutely right. It's very challenging because most studies don't directly compare all three techniques head-to-head in the same well-matched group of patients. Patients selected for open surgery might be younger and healthier, while those getting endovascular might be older with more comorbidities, or vice versa, depending on the center.
Right.
Also, the patients included in these studies often have different extents and types of TAAs, some involving more aorta than others, which can significantly influence the risks and outcomes.
So interpreting the data needs caution.
Definitely. However, there was a recent important analysis that specifically tried to compare all three techniques just for 3 TAAs. These are generally considered higher-risk aneurysms involving a significant length of the aorta. After adjusting for patient risk factors, they found no significant difference in the rates of permanent spinal cord injury or major complications between the three groups.
Okay, so similar major complication rates after adjustment.
In that specific analysis, yes. But interestingly, open repair did have a significantly higher rate of death within the first 30 days compared to FBVAR.
So an early survival benefit for FBR.
Exactly. Furthermore, both FBVAR and hybrid repair showed improved survival rates over 5 years compared to open repair, but this advantage seemed mostly concentrated within the first 180 days after the procedure.
So the survival curves maybe come together later on.
It seems that way, yes. That early survival advantage with endovascular approaches seems to lessen over longer-term follow-up, which is actually similar to what's been observed in some comparisons of EVAR versus open repair for abdominal aortic aneurysms.
Interesting parallel.
It is, but despite the need for more long-term data and the reintervention issue, the current expert consensus, based on the lower upfront operative risk, generally tends to favor FBVAR as the initial first-line preferred treatment for elective TAA repair in patients whose anatomy is suitable for it and who are being treated at experienced centers.
Okay, that makes sense. Now, regardless of the specific surgical approach chosen, open, hybrid, or FBVAR, I know that spinal cord injury is a major dreaded concern with any TAA repair. What specific strategies are employed across the board to try and protect the spinal cord during these procedures?
Yes, spinal cord ischemia or SCI leading to weakness or paralysis is indeed a devastating potential complication. It's something we focus on intensely. We use a combination of strategies aimed at both, making the spinal cord more resilient to periods of reduced blood flow, increasing its tolerance to ischemia, and also actively trying to maximize the blood supply to the spinal cord during and immediately after the repair.
Okay, let's break that down. First, the strategies to increase the spinal cord's resilience or tolerance. What does that involve?
Well, there are some medications that have been explored. Intrathecal papaverine, injected into the spinal fluid, has been studied but has limited adoption currently. Some centers use steroids or naloxone around the time of surgery, but the evidence isn't definitive.
Oh.
A more common strategy is allowing a slight drop in the patient's core body temperature during the procedure, maybe down to 34 degrees Celsius. This technique, called permissive hypothermia, is thought to lower the metabolic demands of the spinal cord and might help reduce the risk of SCI.
Interesting.
Also, if the overall repair is planned in stages, as we discussed for hybrid repair, that can also be beneficial. The delay between stages might allow time for the body's natural collateral blood vessels to develop and provide more robust blood flow to the spinal network, making it more resilient during the second stage.
Preconditioning almost.
Sort of, yes. And along those lines, there's even a novel experimental approach being investigated where surgeons intentionally block off or coil embolize certain segmental arteries that feed directly into the aneurysm sac before the main repair. The theory is that this encourages the growth and strengthening of other, more important collateral vessels to the spinal cord before the main blood supply is potentially interrupted by the graft. But we definitely need more research to understand how effective and safe this selective embolization strategy really is.
Fascinating idea, though. And how do surgeons actively work to increase or augment blood flow to the spinal cord during and after these repairs?
This is probably the most critical part. The primary strategy here is maintaining a higher than normal mean arterial blood pressure, or MAP, both during the surgery and, very importantly, in the intensive care unit afterwards, often for 24-48 hours or more. We typically aim for a target MAP of maybe 90 to 100 millimeter Hg, and might push it even higher if we see any early signs of neurological deficit, like leg weakness.
Keep the pressure up to perfuse the cord.
Exactly. We also very frequently use cerebrospinal fluid, or CSF, drainage. As we mentioned, this involves placing a temporary catheter in the spinal canal in the lower back to drain off some of the spinal fluid.
And how does that help?
By lowering the pressure within the spinal canal, it effectively increases the pressure gradient driving blood flow into the spinal cord arteries. Think of it as lowering the back pressure. Meta-analyses, particularly for open repair, have shown that CSF drainage can significantly lower the risk of SCI. Similar analyses for endovascular repair also suggest a benefit for routine prophylactic placement, putting it in before surgery compared to only putting one in if a problem develops, or not using one at all.
So proactive drainage seems better.
The evidence points that way, yes. Rescue drain placement, putting one in after neurological symptoms appear, may not be as effective. However, there's still some debate about the optimal timing for placement and removal, and whether it should be done absolutely routinely for all extensive endovascular repairs, because the drain itself, while generally safe, does carry its own potential small risks, like catheter fracture, headaches, bleeding around the spine, infection like meningitis, or very rarely, a subdural hematoma, which can be serious.
Right. Always a risk-benefit balance.
Always. Beyond blood pressure and CSF drainage, we also make every effort surgically to preserve direct blood flow to the spinal cord whenever possible. This means minimizing the length of the aorta that is covered by the endograft, if feasible. We also try to maintain inflow to the spinal cord network from alternate routes, like the vertebral arteries coming down from the neck or the internal iliac hypogastric arteries in the pelvis. This might involve proactively revascularizing or bypassing the subclavian artery feeding the vertebral, or the hypogastric arteries if they are at risk of being blocked by the endograft landing zones.
Preserve all potential supply lines.
Exactly. And finally, just good critical care basics. We aim to keep the patient's hemoglobin level up, usually above a 9 or 10 GDL, to ensure good oxygen carrying capacity in the blood and maintain high oxygen saturation levels, typically above 95%. All these factors contribute to optimizing spinal cord perfusion.
That's a really comprehensive set of strategies. Now let's shift our focus finally to aneurysms affecting the aortic air, that crucial curve right up near the heart where the major vessels branch off to supply blood to the brain and arms. I can only imagine that presents its own unique and maybe even greater set of challenges.
You're absolutely right. Aneurysms involving the aortic arch are often considered among the most challenging aortic pathologies to treat. They are rarely isolated just to the arch itself and frequently extend into the ascending aorta just above the heart or down into the descending thoracic aorta as well.
Right.
And the close proximity of those three major arteries, the innominate, or brachiocephalic, the left common carotid, and the left subclavian that supply blood directly to the brain, makes any repair in this area technically demanding and carries significant inherent risks of neurological complications, primarily stroke.
Yeah, that's the big one.
It is. So the decision to intervene on an arch aneurysm, just like with other aneurysms, involves carefully weighing those substantial surgical risks against the natural history, the risk of rupture or dissection if left untreated, while also factoring in the patient's overall health and life expectancy.
And is diameter still the main driver for deciding when to repair?
Aneurysm diameter is still the primary factor guiding the decision, yes. General guidelines from groups like the European Society for Vascular Surgery and the Society for Thoracic Surgeons often recommend considering repair in lower-risk patients when the maximum arch diameter exceeds about 55 millimeters.
Okay, 55 millimeter for the arch.
But perhaps even more so than with TAAAs, diameter alone is often not the sole indication, precisely because of the complexity and risks involved in arch repair. Other factors like symptoms, rapid growth, or specific aneurysm shapes might push towards intervention earlier.
What are some of the specific anatomical considerations that make endovascular repair of the aortic arch particularly tricky? What makes it so difficult?
Oh, there are several key anatomical features that can make an endovascular approach to the aortic arch quite challenging. Firstly, the degree of tortuosity, meaning how twisted and sharply curved the arch itself and the origins of the great vessels are, is very important.
Right, it's not a smooth curve usually.
Yeah. Exactly. Very sharp bends, especially in what we call a type 3 arch configuration, which is a very Gothic-looking arch, can make it incredibly difficult to safely navigate the large, relatively stiff endograft delivery systems around that curve without causing injury or problems deploying the graft accurately.
I could picture that.
Similarly, significant curves, kinks, or blockages within the innominate, carotid, or subclavian arteries themselves can hinder the ability to insert the necessary wires and bridging stents to connect the endograft to these critical vessels. So we need good target vessel access too.
Okay.
We always carefully evaluate the great vessels beforehand, often with duplex ultrasound in addition to CT scans. And we absolutely need detailed CT imaging that includes the blood vessels within the brain itself. We need to assess the circle of Willis and understand the patient's cerebral cross-flow potential, basically, how well blood can get to all parts of the brain if one of the main supply vessels is temporarily blocked or compromised during the procedure.
Critical information.
Absolutely critical for planning and safety. Another major concern is the amount of atherosclerotic burden plaque buildup within the arch and the great vessels. A significant amount of irregular plaque is a relative contraindication to extensive endovascular manipulation because disturbing that plaque with wires and catheters could easily dislodge fragments, causing emboli that travel to the brain and result in a stroke.
Yeah, very real risk.
Very real. Then there's the specific location where we plan to attach the top end of the endograft, the proximal landing zone. If we need to land in what we call Ishimaru zones 0 or 1, which are the parts of the arch closest to the heart, involving the origins of the innominate or left carotid arteries, this often requires placing a very stiff guide wire across the aortic valve and down into the left ventricle of the heart for stability during graft deployment.
Into the heart itself.
Yes, the tip of the wire goes into the LV. And the very front part of the endograft delivery system, the nose cone, might then briefly engage the aortic valve leaflets and slightly enter the left ventricle as the graft is positioned. This is generally considered contraindicated or at least very high risk in patients who have a mechanical aortic valve prosthesis. Although, interestingly, there are some reports of using custom-made devices with very short nose cones specifically designed to try and mitigate this issue.
Wow.
On the flip side, having had prior aortic surgery, like a previous surgical replacement of the ascending aorta, can sometimes actually provide an ideal, stable, and healthy proximal landing zone in the arch, because we're landing the endograft inside that nice, straight surgical graft material.
Ah, okay. Sometimes prior surgery helps.
It can. However, even if landing in a prior surgical graft, we need to make sure there are no sharp kinks or bends in that graft that could cause problems. And finally, landing the endograft in a native non-grafted aorta in the arch that is significantly dilated, say with a diameter greater than 38 or 40 millimeters, carries an increased risk of causing a retrograde type A dissection where the tear propagates backwards towards the heart. So we really try to avoid landing in very dilated native arch aorta, if at all possible.
Okay. A lot of anatomical factors to weigh very carefully. So, given all these challenges, what are the different surgical strategies and the specific stent graft devices used for these aortic arch aneurysms? And what are the general outcomes we're seeing with these newer approaches?
Right. So for managing aortic arch aneurysms, we primarily have three main strategic approaches available today. There's still traditional open surgical replacement of the arch, which often requires deep hypothermic circulatory arrest, basically cooling the patient way down and stopping blood circulation temporarily.
The big open operation.
The big one, yes. Then there's total endovascular repair using specialized fenestrated or branched arch endografts. And thirdly, there's hybrid repair, which, similar to TAAAs, combines surgical rerouting of blood flow to the supraaortic vessels, the brain and arm arteries, followed by the placement of a thoracic endograft, TVAR, into that surgically created landing zone.
Okay.
While open surgery remains a crucial option, especially for certain anatomies or younger, fitter patients, our focus in this deep dive is really on understanding the evolving endovascular and hybrid strategies. The choice between going for a total endovascular repair versus a hybrid approach often depends on several factors.
Yeah.
Exactly where the aneurysm is located and where we need to land the graft proximally, which is Shimari's zone, the availability of specific types of endograft devices, since many are still investigational in the US, and critically the specific expertise and experience of the surgeons and the medical center.
Makes sense. Let's dive into hybrid arch repair first. How does that approach typically work for the arch?
Okay. Hybrid repair for the aortic arch aims to create a suitable, healthy landing zone, usually in the distal arch or proximal descending aorta, zones 2 or 3, for a standard thoracic endograft, TAAA. It does this by surgically debranching or rerouting the blood supply to 1, 2, or sometimes all 3 of the great vessels that normally come off the more proximal arch.
So you move the pipes first, then put in the stent graft.
Exactly. For example, if we need to land the TAAA in zone 2 of the arch, meaning we need to cover the origin of the left subclavian artery, we might perform a surgical bypass from the left carotid artery over to the left subclavian artery, or sometimes just move the origin of the left subclavian artery and sew it onto the side of the left carotid artery, a transposition.
Okay.
If we need to land more proximally, in zone 1, covering the left carotid origin as well, we might do a bypass from the right carotid artery over to the left carotid, plus the carotid subclavian bypass or transposition.
Right.
And for landing even more proximally, in zone 0, covering the innominate artery origin, the debranching becomes more complex. It usually involves a bypass graft originating from the ascending aorta itself, which requires opening the top part of the sternum, a partial sternotomy, and then creating bypasses from that graft up to the innominate artery and maybe the left carotid artery. This can often be done without putting the patient on full heart-lung bypass, but it's still a significant open chest procedure.
Okay, so varying degrees of open surgery depending on the zone.
Correct. These debranching surgical procedures can be performed either as a first stage, before the FBVAR placement, or sometimes at the same time as the TAAA placement in a single combined operation.
And what's the main advantage hoped for with hybrid?
Well, the main theoretical advantage of hybrid repair over a full traditional open arch replacement is avoiding the need for cardiopulmonary bypass and that period of deep hypothermic circulatory arrest, which carries its own significant risks.
Right, avoid the heart-lung machine.
That's the goal. However, it's crucial to remember that any surgical manipulation of the aortic arch itself and the great vessels during the debranching carries an inherent risk of stroke from dislodging plaque. And the debranching bypass surgeries themselves also carry risks, like bleeding or graft issues.
True.
Hybrid repair also requires that the patient has good quality access vessels in their legs or arms for the TAAA delivery, and is generally not considered the best option if the intended proximal landing zone in the aorta has a high risk of retrograde dissection, like in that very dilated native aorta we talked about, or perhaps in patients with certain connective tissue disorders or a bicuspid aortic valve.
Okay. And how did the outcomes look compared to open?
That's where it gets a bit murky. Well, the initial hope was that hybrid repair would significantly improve outcomes compared to traditional open surgery. Some large meta-analyses and registry studies haven't consistently shown a clear advantage in terms of early or late mortality. In fact, some have even suggested a slightly increased risk of neurological complications like stroke with hybrid repair compared to open.
Oh, really? That's surprising.
It is, but these findings need to be interpreted with a lot of caution. These studies often suffer from significant bias, comparing different patient groups treated at different times or different centers, and have other limitations. So the jury is still somewhat out on the precise role and benefit of hybrid arch repair versus open, but it remains an important option, especially for higher risk patients who might not tolerate the full open procedure.
Okay. What about a completely endovascular approach for the aortic arch then? Using those specialized grafts. That sounds like the most minimally invasive and therefore potentially the most appealing option, at least theoretically.
It is indeed often seen as the new frontier in treating aortic arch aneurysms, offering a potential alternative, particularly for patients who are deemed too high risk for either traditional open surgery or maybe even the hybrid approach. However, it's really important to emphasize that total endovascular aortic arch repair is still in a relatively early stage of development and clinical implementation, especially here in the US, where most devices are still investigational. And as practiced currently, it does carry a moderate, non-trivial risk of neurological complications, particularly stroke.
Still a significant risk then.
Yes. So we're still very much in the process of learning which specific patient groups will truly benefit the most from this totally endovascular approach, and how to optimize the techniques, the devices, and the peri-procedural management to minimize those risks.
Makes sense. So what are the main types of specialized endografts being used or developed for this total endovascular arch repair? You mentioned fenestrated and branched.
Correct. We primarily have two main design concepts for dedicated arch endografts: fenestrated grafts and branched grafts.
Okay, tell me about the fenestrated ones first.
Fenestrated arch endografts are designed with very precisely placed openings, or fenestrations, in the graft fabric. These are often wider openings, sometimes called scallops, compared to the small fenestrations used in the TAA grafts, and they're designed to align with the origins of the great vessels, the innominate, left carotid, and left subclavian arteries, allowing blood flow into them.
Right.
The most extensive clinical experience with fenestrated arch grafts actually comes from Japan with a device called the Najuta graft. This graft has a unique pre-curved design specifically for the arch, incorporates these fenestrations, and interestingly, often doesn't require the placement of additional bridging stents into the great vessels themselves.
Oh, no bridging stents needed.
Often not, or only selectively. And the early results reported from Japan with the Najuta graft have been quite encouraging, showing relatively low rates of operative mortality and stroke. One theory is that maybe because there's less direct wire and catheter manipulation within the arch and great vessels needed for deployment compared to branch grafts, the stroke risk might be lower. This device is commercially available in Japan.
Okay. Any others?
Yes, another fenestrated device is the Cook Zenith Fenestrated Arch Endograft. This is a custom-made device, CMD, tailored to the individual patient's anatomy based on their CT scans. Unlike the Najuta, it does typically require the use of bridging stents to connect the fenestrations in the main graft securely to the great vessels. Initial experience reported from a large series in Germany with this device showed somewhat higher rates of mortality and stroke compared to the early Najuta graft reports, highlighting the technical challenges and perhaps a learning curve effect.
Okay. And you also mentioned branch arch endografts. How do those work differently?
Branched arch endografts take a different approach. Instead of just holes, they have actual branches, like short, pre-sewn tubes that extend off the main body of the graft, usually along its outer curve. These branches are designed to align with the grit vessels and direct blood flow into them in an antegrade or forward direction from the main graft lumen.
Got it. Tubes instead of holes.
Essentially, yes. There are several different branched arch endograft devices in various stages of development and clinical testing globally. One is the Bolton, now Terumo Relay, dual branch endograft. This device is designed for treating aneurysms involving zone 0 of the arch, the most proximal part. It has two internal branches and uses a unique dual-sheath delivery system with a pre-curved cannula to help navigate the arch. The branches are typically accessed and cannulated from a retrograde approach, often via surgical access to both carotid arteries in the neck, requiring the placement of bridging stents to connect them. The left subclavian artery usually needs to be dealt with separately, often with a surgical bypass or transposition beforehand.
Sounds complex to deploy.
It is technically demanding. Initial results reported from Europe showed pretty good technical success in terms of placing the graft and achieving aneurysm sealing, but there were unfortunately substantial rates of both mortality and stroke reported in the early experience, although some later data suggests that these outcomes do tend to improve significantly as surgeons and centers gain more experience with the device and refine patient selection and technique. A U.S. feasibility trial is ongoing.
Okay, learning curve again. Any other branch devices?
Yes. Cook Medical also has a branched arch endograft, the Zenith Branched Arch Endograft platform. This can be designed with either 2 or 3 internal branches. The more proximal branches for the innominate and/or left carotid are usually directed antegrade, while the branch for the left subclavian artery is often designed for retrograde access from the arm. It uses a pre-curved inner cannula, called a hypotube, to help direct the branches. This device has been used clinically in Europe for about a decade now under special access programs and is currently undergoing physician-sponsored IDE trials in the U.S. Bridging stents are required and are typically placed via surgical access to the carotid and/or axillary arteries. Again, outcomes have generally improved with increased experience and technical refinements over time. Additionally, there are several single-branch endografts currently in U.S. clinical trials, which are perhaps simpler in concept. Examples include the Goretag thoracic branch endoprosthesis, TBE, and the Medtronic Mona LSA device. These are primarily designed for treating pathology involving zone 2 of the arch, essentially providing a dedicated branch just for the left subclavian artery or perhaps the innominate artery. For aneurysms involving zone 0 or 1 closer to the heart, they would typically require a surgical debranching procedure first, making it more of a hybrid approach. Early results reported from the trials of these single branch grafts have generally been quite promising, showing high technical success and relatively low rates of major complications for their intended Zone 2 indication.
So lots of development happening in the branch graft space. It sounds like there are also some alternative endovascular solutions for the aortic arch beyond these main fenestrated and branched grafts that are specifically designed for the arch, like maybe using techniques borrowed from other areas.
Yes, absolutely. For situations where a dedicated arch branch or fenestrated graft isn't available, isn't suitable, or perhaps in more urgent scenarios, surgeons have adapted other techniques. One is the chimney or parallel graft technique.
Chimneys in the arch.
Exactly. Similar to how it's sometimes used in the abdominal aorta, covered stents are placed originating from within the main thoracic endograft and running parallel to it up into the great vessels, like the carotid or subclavian. This effectively extends the proximal seal zone of the main TAAA up into the arch while preserving flow to those critical branches. A potential advantage is that this can often be done using commercially available, off-the-shelf components, which makes it readily available and potentially useful in urgent or emergent situations. However, there are definitely some concerns associated with the chimney technique in the arch. One is the potential for gutter leaks, small leaks between the parallel chimney stents and the main graft wall. There are also questions about the long-term patency or openness of these chimney stents, as they might be prone to compression or blood clots over time. While short-term results in selected cases seem reasonably satisfactory, it's generally not considered anatomically or hemodynamically equivalent to the more purpose-built integrated arch grafts, but it remains a useful bailout or alternative strategy in certain situations.
Got it. Any other alternatives?
Another option that's gaining some traction is in situ fenestration. This is where we intentionally create a hole or fenestration in an already deployed standard thoracic endograft using specialized tools passed up from the groin or arm, like a crossing needle combined with a snare, or sometimes using laser energy or radiofrequency ablation catheters.
Making the hole after the graft is already in place.
Exactly. This is most commonly done to preserve or restore blood flow to the left subclavian artery if it gets covered by the TAAA. But there are some reports, mostly case series, of surgeons using in situ techniques to create multiple fenestrations to salvage flow to all three great vessels for aneurysms involving zone 0. This often requires temporarily diverting blood flow to the brain using protective shunts during the fenestration creation process.
Sounds very technically demanding.
Extremely. The technical success rate of actually creating these fenestrations is generally reported to be quite high, and the early rates of mortality and endoleak seem relatively low in experienced hands. However, we still need much more data on the long-term durability and potential consequences, like material fatigue or late leaks, associated with creating these unplanned holes in the graft fabric. Physician-modified endografts, like we discussed for TAAAs, where a surgeon customizes a standard thoracic endograft on the back table before implantation, are also sometimes used as an option for treating certain types of aortic arch aneurysms in specific circumstances, particularly outside the U.S., where custom device access might be easier.
Okay, a range of creative solutions being employed. Now, given that particularly high risk of stroke we keep mentioning with any aortic arch procedure, what specific neuroprotective strategies are employed during these endovascular arch repairs? Is it different from TAA repair?
Stroke is absolutely the dominant concern with any aortic arch intervention, whether open, hybrid, or total endovascular. So neuroprotection is paramount. Careful patient selection is probably the single most critical neuroprotective strategy, avoiding extensive manipulation in patients with very heavy plaque burden in the arch, for example.
Right. Prevention is key.
Definitely. Beyond that, we also rely heavily on various intraoperative monitoring techniques to try and detect any signs of reduced blood flow or embolic events happening in the brain during the procedure, hopefully allowing us to react quickly. However, similar to the situation with spinal cord monitoring, there's no single monitoring method that is universally considered the best or proven to definitively prevent stroke. The choice of which monitoring modalities to use often depends on institutional preferences, availability, and the experience of the surgeons, anesthesiologists, and neurophysiologists involved.
What are some of the common monitoring techniques used?
Several are used, often in combination. Near-infrared spectroscopy, or NIRS, is a non-invasive technique that uses sensors placed on the forehead to monitor oxygen saturation levels in the brain tissue underneath. It can potentially detect global reductions in cerebral oxygenation, indicating ischemia, and some studies suggest it correlates reasonably well with other methods like TCD or EEG. However, a clear threshold for intervention based on NIRS readings is poorly defined, and it really only assesses the frontal lobes of the brain.
Okay.
You also need a clear algorithm for how to respond if a desaturation is detected.
Okay. What else?
Electroencephalography, or EEG, directly measures the electrical activity generated by the brain cells and is commonly used during carotid artery surgery to detect ischemia. It's often combined with somatosensory evoked potentials, or SSEPs, which measure the brain's electrical response to stimulation of nerves in the limbs, like the median or tubule nerves. Combining EEG and SEPs is thought to increase the sensitivity for detecting cerebral ischemia. A limitation is that anesthetic agents themselves can affect the EEG readings, so interpretation requires expertise. Another important tool is transcranial Doppler, or TCD. This uses ultrasound probes placed on the temples to monitor the blood flow velocity in the major cerebral arteries, typically the middle cerebral artery. It can detect significant drops in flow velocity, suggesting reduced perfusion, and importantly, it can also detect microembolic signals, tiny bubbles or particles traveling to the brain, which might occur during wire manipulation or device deployment. Relative changes in velocity are generally considered more accurate than absolute values, and a limitation is that about 10–15% of people don't have a good acoustic window through their skull for the ultrasound signal.
So TCD can see clots, potentially.
It can detect signals consistent with emboli, yes, which can be very useful feedback during the procedure. Now, if there's also considered to be a high risk of spinal cord ischemia during the arch repair, perhaps because the endograft extends far down the descending aorta, then we would absolutely employ the same measures we discussed earlier for TAA repair to augment spinal cord perfusion. Things like maintaining higher mean arterial pressure goals and likely using a CSF drain. In those high-risk spinal cord cases, we might also add continuous motor evoked potentials, or MEPs, to the monitoring armamentarium. MEPs assess the integrity of the motor pathways from the brain down the spinal cord by stimulating the brain and recording the response in limb muscles. They can provide very early warning signs of spinal cord injury, potentially allowing for intraoperative maneuvers like raising blood pressure further to try and reverse the changes.
It's amazing the level of monitoring involved. This has been an incredibly thorough and detailed exploration of the strategies for addressing these really complex thoracic and thoracoabdominal aortic aneurysms using these evolving endovascular techniques. It's really clear that this is a rapidly advancing field.
It truly is. We've covered a significant amount of ground today, haven't we? From the detailed aspects of device selection like fenestrated versus branched grafts, the different surgical techniques for TAAs like FBVAR and hybrid, all the way up to the specific challenges and these emerging solutions for aneurysms involving the aortic arch. The advancements in endovascular technology over the last couple of decades have just been remarkable,
Yeah.
providing less invasive options for many patients who, in the past, might not have been suitable candidates for the major traditional open surgeries or for whom open surgery carried prohibitive risks.
And it really underscores just how personalized and tailored these procedures are becoming. It's clearly not just about the aneurysm itself, but about meticulously considering each individual patient's unique anatomy, the curves, the branches, the plaque, their overall health status, and critically, having highly skilled, multidisciplinary medical teams with specialized expertise in these advanced techniques.
Absolutely. Achieving successful outcomes in this area relies so heavily on that comprehensive, individualized approach, careful planning, meticulous execution, and the continuous refinement of both the technology itself and the clinical skills involved. It's a real team effort.
Definitely. And on that note, here's a final thought for you, the listener, to ponder. Considering this rapid pace of innovation we've discussed, particularly with these complex and often costly endovascular technologies, what ethical considerations do you think arise regarding equitable access to these treatments? And how might future research or healthcare policy work towards addressing potential disparities in who can benefit from these advancements? Something to think about. Thanks for joining us for this deep dive.